Thank you. Distinguished members of the government of Turkey and international visitors and members of the Green Crescent Society and ladies and gentlemen, it's a great pleasure for me to be here today to talk about the public health approach to dealing with substance use disorders throughout the world. I'm going to try to describe one version of a public health approach, which is a combination of concepts and policies and programs that are based on scientific evidence as we know it today. The concept of public health includes services for individuals. Often these are described in terms of prevention and treatment organized within programs. But public health is much more than that. It's services to deal not only with individuals, but also with populations and trends in population health. It's not only services, but it's systems of services in organizing and coordinating those services. And it's more than just creating programs, it's creating policies that design the environment, the infrastructure to allow those programs to focus, to have a population impact. So what I'm going to describe is the results of research that have been effective over time hopefully in contributing to the reduction in substance abuse around the world. Much of my talk is going to be derived by a collaborative effort over the past few years to organize the scientific literature relevant to this public health approach to substance abuse. The book is called Drug Policy and the Public Good. It was written by an international group of authors who are career scientists who reviewed the scientific literature to inform policy at the local, national, and international levels. We reviewed more than 900 articles, systematic literature reviews, scholarly books, and government reports in order to evaluate what seems to work and perhaps what seems not to work. Much of what we found in our analysis of the literature is relevant to the political declaration coming out of the United Nations starting in 1998, but also revisited in 2009. And the General Assembly of the UN declared that substance abuse continues to be a serious threat. So if what we were doing during the past 15 years or the past 30 years were having a dramatic impact, we would have seen a lessening of the problem. We have not seen that to date. The system or the situation would probably be much worse if we had not had the programs and the policies and the treatment and the prevention that have been developed. But nevertheless, we need to do much more. And the value of a public health approach, according to the political declaration and the plan of action, is to coordinate and integrate all of the various evidence-informed programs that we've developed to date. And if we can do that on the level of primary prevention, early identification, treatment, rehabilitation, and supply control policies, we may be in a much better position to change the prevalence of substance use disorders around the world. The public health approach includes the integration of supply control efforts and demand reduction, and the goal is to increase the population impact of these measures. The coordination of substance use services and programs and policies is designed both to deal with emerging epidemics that periodically develop within communities or within countries, as well as endemic drug use. And what we've seen in many countries is the stabilization, a very unfortunate stabilization of prevalence rates, particularly among young people, in their use of cannabis and alcohol and tobacco, with trends that vary up and down by 10 or 15% over a few years. And if we can learn what accounts for those variations in trends, whether our policies and our programs are affecting them, we might be able to improve the public health approach. The types of evidence that are available to inform drug programs and drug policy include randomized clinical trials, descriptive epidemiology, the study of the distribution and determinants of drug problems, quasi-experimental correlational studies, where we look at the comparison of programs or countries in a way that doesn't allow us to randomize people to different conditions, but certainly informs our understanding of what kinds of programs are having an impact. Qualitative research, health services research, historical research, economic research, all of these different areas will contribute and continue to contribute to our understanding of how to deal with endemic and epidemic drug use. We have a number of supply control and criminal justice approaches that have been tried throughout the last half century, including crop eradication, alternative development by building up countries that are not functioning at a level where they can regulate the production of psychoactive substances for distribution in the international market. Precursor control, particularly in the area of methamphetamines, interdiction at a country's border, high-level enforcement of drug cartels and drug traffickers, street-level enforcement, imprisonment, prescription regimes to prevent the diversion of psychoactive substances that have medicinal purposes and are used for non-medical reasons. All of these programs have been developed to reduce the supply and the cost of drugs. And we've learned from a number of research studies that the supply control interventions can produce market disruptions. They can raise the price of drugs on the street when drug production is curtailed in some countries. But the effect is often transitory, and once the production lines are established, the distribution lines, the market for the drugs is established, it's difficult to reverse. We've learned that street-level enforcement can be effective, but it is probably not a viable strategy for reducing drug use in the long term. It is just one of many approaches that we've got to better coordinate. Although supply control interventions absorb the bulk of the drug control spending in most countries, the evidence supporting these interventions is not strong, in part because it's very difficult to do research here, in part because the effects are transitory and they need to be combined with other approaches, particularly demand reduction approaches. So, what do we have available? We've got school drug prevention programs and mass media campaigns designed to change attitudes and improve health literacy and prevent the onset of drug use. We have secondary prevention programs that are now being distributed worldwide in primary care settings in order to get general medical practitioners to take a greater role in early identification of substance abuse, whether it's tobacco or alcohol or illicit substances, and intervening at the level of primary care. We have treatment programs for opiate substitution therapy, counseling, therapeutic communities, self-help organizations that reduce crime and overdose deaths and prevent the spread of HIV infection. And we have harm reduction approaches that are designed to deal with overdose and infection. As you're going to be learning in other sessions in this series of presentations from people around the world, family and school environment programs in the prevention area have been found to be effective in discouraging young people from initiating drug use and progressing more rapidly to heavy drug use. These programs are often labor intensive, and they need to be delivered with fidelity in order to have an impact. But we've learned that it takes the involvement of the teachers, of the school administration, of the parents, of the community, in order to have an effective prevention approach. And even there, the impact is not as dramatic as we would like it to be. Moving on to secondary prevention. The secondary prevention is a concept which is classical in public health. It's designed to approach people who have begun to demonstrate that they are engaged in risky behavior or they have other risk factors that are going to affect their health. Early intervention programs conducted throughout the world have shown promise when they've been evaluated systematically through randomized clinical trials. They usually include the use of screening tests such as the ones developed by the World Health Organization and translated into many languages. And when patients are systematically screened within a healthcare setting for tobacco, alcohol, and other drugs, and given a brief intervention, which could be as simple as a few minutes of conversation between a healthcare provider and the patient, we can find that many patients resolved and are motivated to change their substance use behavior. An example is a study done, sponsored by the World Health Organization in 4 countries, India, Australia, Brazil, and the USA, which randomized patients who were not addicted to illicit drugs, but were using drugs in a way that was highly risky and likely to progress perhaps to drug dependence. And when these patients were identified through a screening test, they were given feedback about the level of risk by a healthcare provider, and they were given encouragement and advice and a self-help manual and support to modify their substance use behavior. When they were followed up 6 months later, we found a statistically significant difference, a clinically significant difference between the control group that did not receive the intervention and the experimental group that did. This, as well as other trials, not all of the other trials, but many of the other trials, both in alcohol and tobacco, and we know that these kinds of interventions can work well for tobacco. This gives us a sense of optimism that by engaging the broader healthcare community, we can have an impact not only on individuals, but on large numbers of patients who come into healthcare settings around the world. Think about it, just about everyone in the world sees a healthcare practitioner at least once a year in most countries. And if that is the case, and if every person considered to be at risk were screened and given advice and encouragement and support to cut back on their substance use and avoid it because of health reasons, we may be able to reach a significant number of people. Treatment and harm minimization are also important parts of this public health approach. And we know that services for opiate-dependent individuals have very strong supporting evidence, and not only to reduce drug use, but drug-related crime and HIV infection. Harm reduction programs such as needle exchange reduce high-risk injection practices and engage injection drug users in treatment and health services. And research demonstrates the effectiveness of these programs. In the case of cannabis dependence, a remarkable study that I was involved in the United States randomized patients either to a waiting list control group after it had been identified that they were chronic drug users, cannabis users, an average of 7 years of daily use. Those patients who were involved in the study and got 2 sessions of motivational interviewing reduced their cannabis use significantly as a function of the advice that they got and the planning that went on between the healthcare provider and the patient. If they got up to 9 sessions of brief treatment, the effect was even more dramatic. So we can see, even for chronic substance users, cannabis users, if they have never been treated before and they have the opportunity to be engaged with treatment providers in a program designed just to deal with cannabis dependence, that many of them will respond positively to treatment. And this is true of much of the experience that we've had in evaluating treatment programs over the years. Consistent with the integrated and balanced approach that the UN Political Declaration has asked for, we have research demonstrating that collaboration between drug treatment and criminal justice is a very effective way of promoting abstinence in people engaged in the criminal justice system after they have been apprehended. And following that, when they get out of prison, it's another time in their life when there's a high risk of returning to drug use and overdose. And here again, prison programs that provide treatment within prison or right after a person is being released are effective in discouraging drug use and reducing overdose deaths. So what we can see is that the treatment system can serve as a public health intervention if the services are made more accessible, more efficient, more economical, and continuity of care is provided. We can increase the population impact of these kinds of services. And that, in a sense, is the essence of a public health approach. I'm going to stop here and thank you for your attention.